Well, welcome everyone, and thank you for joining us today. My name is Bill Manning, and I'm Executive Director of ASPI. A quick footnote, I have been on active surveillance since 2009, and I'm still a member of my local support group that got me started on this journey. Our purpose here is to educate individuals about options regarding AS, which is not a treatment, but a management plan. I would like to remind everyone we are not anti-treatment, but anti-unnecessary treatment. We are not here to dispense with any medical advice. Nothing said during these meetings by our speakers, ASPI, or the audience should take the place of your consultations with medical professionals. We are going to divide up the presentation into several parts, and there will be a pause after each section for a limited number of questions. So we ask you to submit those questions into the chat box, and then at the end of the presentation, we'll open it up for all questions. And we'll get to the chat questions first. And if you want to actually speak, raise your hand and we'll try to call on you. The meeting is being recorded and will be available on our website. It's usually about 1 week, and you'll get an email notifying you when it's ready. Also, if you subscribe to our YouTube channel, you'll automatically be notified when a new video is posted. But please like to remind you to stay muted during the meeting. And when we do open it up for questions, please raise your hand first so you can be called on, and we'll keep this nice and orderly. So without further ado, we'll have a few quick words from our chairman, Mark Lichty, who will turn the meeting over to Howard Walensky, the organizer of this meeting, to introduce our guest. So relax, enjoy the meeting, and I hope you leave a little bit smarter. Take it away, Mark.
Thank you, Bill. I'm chair of ASPI, and we try to create a little bit of a sanctuary where you can find some peace on a Saturday morning. I wanted to first say that this Brotherhood of Prostate Cancer Patients is an unusual forum. I shared last week that my cancer had spread to a lymph node after 20 years. And it was interesting because out of that sharing here, somebody got in touch with me. I wish I remembered his name and said, Mark, okay, the recommendation for me was that I would need ADT, androgen deprivation therapy, and then radiation. And he said, after searching me and finding me, he said, Mark, were you aware that a study was done and the longevity with ADT and radiation is the same whether you had ADT or not? So I'm likely going to drop the ADT based on that phone call. And that's the exciting thing about this group. Actually, I should say in passing too that we have a cavemen group, a support group, well, a number of support groups as well. And then any of you are welcome to join. And if you're interested in that, you should email us and let us know that you're interested in joining that. But I wanted to make a public thank you, do a public thank you to Howard Walensky, who's the author of The Active Surveiller. And if you haven't subscribed yet to The Active Surveiller, do. It's such a wonderful source of information on active surveillance. And thank you, Howard, because Howard cares. He cares about you. He cares about us. He is who nudged me to get a second opinion on my radiologist's opinion. And so I am ASPI's message is about getting part of the message. Part of the message is about getting second opinions. And here I was with a radiologist, and I hadn't yet gotten a second opinion. So, anyway, Howard, thank you for that. And with that, I'd like to introduce Howard Walensky.
Oh, hi. Uh, I don't know. I guess you can say I care. You can say Big Brother is watching as well. But uh, let's get on with this. Following prostate biopsies, pathologists prepare reports outlining their findings, such as features of the prostate, like cribriform pattern or perineural invasion or your Gleason score. Under federal law in the US, the 21st Century Cures Act, enacted in 2016, doctors are required to release pathology results to patients as soon as they're ready. Patients may read these results before their doctors do. And where does that leave them? But we patients may not understand the results, even the Gleason scores, and may misinterpret the findings. Even our our urologists can misinterpret these reports, which really are aimed at the doctors and not necessarily us, the patients. That's the topic of today's webinar on cracking the code of pathology records and Gleason scores. Our speaker is Dr. Cathryn Lapedis from the University of Michigan. I have to say, go blue, because I was a journalist in residence at Michigan, in the Mike Wallace Fellowship Program. Dr. Lapidus is a clinical assistant professor specializing in public health and pathology. Her work focuses on improving how pathology results are communicated. Today, she'll be doing a number of things in 3 different segments, but she's going to explain normal and cancerous cells, Gleason scoring, and how to understand pathology reports. I'm going to turn the platform over to you, Dr. Lapidus.
All right. Good afternoon, everyone. So I'm Dr. Cathryn Jean Lapedis. I'm a clinical assistant professor at the University of Michigan and also at the VA Ann Arbor, in Ann Arbor. And today we're going to talk about cracking the code on pathology reports, helping patients navigate Medicalese to get better health results. And I don't have those. If I'm not speaking loud enough or you have trouble hearing me or I'm speaking too fast, please just type it in the chat, and the moderator, please interrupt me. Okay, so thank you so much for having me here today. This is just a quick snapshot of who I am so that you can get to know me a little bit. I'm originally from Philadelphia. My parents and brother still live there. I went to University of Richmond for undergrad, and then I went to the School of Public Health at University of Michigan for a master's program. And I studied health behavior and health education, and that kind of colored everything that I've done since then in my career. I went to Michigan State University for medical school, and I was at the Flint campus. I met my husband, and we headed off to Boston, where I did my residency at Boston University. And then I did 2 fellowships at Brigham and Women's Hospital. We had our first daughter, and then we moved back to Michigan to be close to family, and I did a GI pathology fellowship there. I then did a 2-year health services research program at the Institute for Healthcare Policy and Innovation through the National Clinical Scholars Program, where I got a lot of time to start thinking about pathology communications. And I also had twins. And then I started my position at University of Michigan and the VA Ann Arbor. And I started thinking a lot about prostate cancer. And I started thinking a lot about how we communicate results, pathology results, to patients. My family has grown, and my twins are now 7 and my daughter is 9. So that's a little bit about me. So pathology, the way the pathology field works, research is traditionally thought of as, we start with the patient and we do investigations into the tissues, the cells, the genes, the molecules that lead to the cancer. And perhaps due to my background in public health, I've always found myself more interested in what happens after we make the diagnosis. How does our report change behaviors of the clinician and the patient? How does it affect people's families, communities, and even the world? do our diagnoses change behavior in a way that improves patient outcomes? And most importantly, is anybody really understanding it? Is the patient understanding the report? Is the doctor understanding the report? And I strongly believe that it doesn't matter if the pathologist makes an accurate diagnosis if the doctors, patients, and families can't understand them. So, if it's just accurate to another pathologist, but the patient misunderstands it or the doctor misunderstands it, then I'm not doing my job. So my mission in my career is to improve communications between pathologists and the patients and doctors we serve to support compassionate, informed, safe, high-quality care. So my outline for today, part one, we're going to talk about pathology reports, what's working and what's not. Part two, we're going to talk about pathology explanation clinics, what happens when a patient meets with their pathologist. And then in part three, which is the shortest section, there'll be a few helpful resources for your next pathology report. I saw some people typing in the chat, like, what's high-grade PIN? What does that mean? I'll give you a few good resources where you can Google those things. So with that, we'll start with the first section, pathology reports, what's working and what's not. So here we are here. So I'm going to give you an overview. Howard mentioned this a little bit, but we're going to start with, okay, the patient has had their biopsy. The tissue goes to the pathologist. So we're at the pathologist. The pathologist is going to look at it under the microscope, and they're going to say, okay, what's going on here? They're going to figure out what the patterns are, everything about the cancer, and they're going to put all of that information that they took a long time looking through and making decisions on, and they're going to put it in a report. And the report is going to go, traditionally, it went to the urologist, and the urologist relayed the information to the patient. And sometimes the patient got a copy of the report, and sometimes they didn't. It was kind of like if they really asked for it or wanted it, sometimes they would get it. But just as Howard said, since the 21st Century Cures Act in the US now, patients and their urologists are getting the report at the exact same time. And so this is interesting because we don't know if patients can really understand this data. It's written for other doctors, and other doctors might not even have an easy time understanding it. So that's one area of research. What happens to the patient? Are they able to understand this report? So we'll talk through that today. And then sometimes the patient will call the urologist and say, oh my gosh, I got this report. What does it mean? I'm, nervous about it. Or sometimes the urologist will call the patient before they've even read it, or they'll talk to them about it later on. So there's this dialogue that usually goes through the patient and the urologist. Sometimes the urologist will ask some questions to the pathologist, say, hey, I don't understand this. But most of the time, this written report is the only way that the pathologist is communicating to the urologist. And there's no good system for patients to ask questions to the pathologist. And some of my research is in this area too. What happens when a patient and a pathologist have a meeting? All of these interactions are embedded within the healthcare system, and they relate to quality of care and patient safety. So every time we change something in here, it's going to potentially have an impact on patient safety and quality. And so I'll explain some of those impacts that we've had seen in our research. All right, so Howard and Ted have agreed to share their stories on receiving their prostate biopsy results. So I'm going to open it up first to Howard. And this is a copy of his report that he so generously shared with us. And so Howard, I'm wondering if you could tell me about your experience of getting your prostate biopsy diagnosis from the pathology report. I believe you got it initially from your doctor, but then you had it from the pathologist as well.
Right. Well, I predated the Cures Act of 2016. I predated it by 6 years. So there was no real system for me to get that report, back in 2010. I got a call on a Friday night. You're in trouble when you get called on Friday night by a urologist who basically said, you have cancer. He didn't explain anything more about it. And in fact, when I saw him in person, he just said, I have good news and bad news. The bad news is you have cancer. He didn't say you have low risk Gleason 6 cancer.
Mhm.
Uh, the good news, he could operate on me next Tuesday. Well, I got a second opinion at the University of Chicago, and I must have gotten the biopsy report from him. And one thing just jumps out at you from that report. One word, malignant. Well, that's pretty heavy.
Mhm.
Um, I probably knew very little about any of this in 2010, and that's a problem. Newly diagnosed patients are at a disadvantage. I mean, it's a shock to get this news, and then you have all this medicalese thrown at you. What does it even mean? So I would say first, malignant. I think it was overkill and scary, but it made a point. And then
Mhm.
all of these locations in the
Mhm.
prostate, I didn't know what that meant. And I was probably pretty vague on Gleason scores. So,
Mhm. Mhm. That sounds pretty typical of what all patients getting their pathology reports now are telling us. So just in case you have a similar pathology report to what Howard has, um, I want to draw your attention to a couple of things. So the Gleason score is here. It's 3 + 3 = 6, and we're going to go through that extensively later. It's 15% of the tissue. So that means like if you have the core, how much of that core in that one biopsy is cancer? It's just 15%. So it's a little spot. And it's 3 + 3 = 6, which is the lowest score that you can have for Gleason score. And then one other thing to point out over here is it's 1 out of 14 cores. So that's 7% of all the cores. So out of all the cores that they looked at, only one of them was positive. So I'm just going through that so that in case other people are looking at their pathology reports and have similar questions. And we'll go through everything more in depth. Thank you so much for sharing that, Howard. Ted is also going to share his experience here. And Ted, my first broad question is if you could just tell us about your experience of getting your prostate biopsy diagnosis and pathology report.
Sure. And I remember it was a Friday afternoon, like early afternoon. I saw an email from the hospital saying that my lab results were ready. So, of course, what do you're sitting on pins and needles waiting for the results. So, of course, you're going to log in and check it out. And
Mm-hmm.
I'm going through it one by one. I forget if it said like negative or benign or non-malignant. I forget what the terminology was, but I knew it was good news. So with each sample or core, like it was good news, good news, good news. Then I got to number 11 of 12 and I saw carcinoma. And my first thought was, and pardon the language, but I'm putting my headspace where I was 2.5 years
Yeah.
ago. I saw carcinoma and I went, holy fuck, I have cancer.
Mm-hmm.
Um, and I thought, okay, what do I do now?
Mm-hmm.
And it was just a little before 2 o'clock. I'm thinking my urologist hopefully is back from lunch. I don't know what his working hours were. So I immediately call, assuming he had not seen the results. So I called, got voicemail, and I just said, please, like this is a message for the doctor. I appreciate he probably hasn't seen the results, but I have cancer. I need him to call me back as soon as possible. This was a little before 2 o'clock, so I figured he still has the afternoon to call me back. When
Mm-hmm.
he gets a message that one of his patients has cancer, he's going to pay attention. I hear nothing. So a little before 4:30, I call again and I just say, I have cancer. I really do need to speak to you before the weekend. Get nothing.
Oh.
So the whole weekend, I'm just at my wit's end, not knowing what's going on or what to do. I so then like I called my GP first thing Monday morning, and that guy's a prince. Um, yeah, I didn't hear from my urologist until it was late Monday. Like, thank you very much. And as for the rest of it, I truly did not understand the results. When I saw the Gleason score, 3 + 3, I now know it's the best score you can get. But my thinking is if that's 6 out of 10, then surely it's better to have a 5 or a 4 or a 3. So, yeah, I was very, very concerned at the time.
Yes, thank you so much for sharing your experience. That's really helpful and an incredibly common experience, unfortunately, for so many people. These reports are not written with patients in mind, and now patients are getting them immediately on Friday afternoons. And the doctor is probably like, "Oh yeah, we're fine, active surveillance." Like the doctor, your urologist has like processed all of that, is not worried, is like, I got to call back the high risk people, and they don't call you back, but on the other end of that, there's a person who's really, really anxious, who is really nervous. A lot of times patients say things like, I was hit with a tidal wave of panic. Yeah, I mean, I think many of us, even outside the prostate cancer community, have gotten test results and experienced a similar tidal wave of panic. And so in this talk, I want to talk about some things that we can do to ease that experience and to really provide more patient-centered communications at the time of diagnosis, because it really is something that, now that it's legally mandated, it's something that's going to happen to so many people. Okay, so I'm going to get a little bit into my work on how much people are commonly able to understand from standard pathology reports, and what are some things that we can do to change that. And I'll go through one of my research projects for that. So as we've talked about, due to recent legislation in the US, patients are increasingly receiving their pathology reports through their patient portal. Most patients are eager to see their pathology reports. So 90% of patients prefer their results to be delivered via the patient portal, and 96% of patients prefer immediate release of their test results, even if their healthcare practitioner has not yet reviewed them. So overall, people are saying, yeah, I want it now. And there's some other things that we can talk about with that later on as well. I'm sure it'll come up in questions. Patient portals can benefit patients by allowing for better care coordination, enhanced doctor-patient relationships, improved health status awareness, and increased adherence to therapy. Unfortunately, standard pathology reports, as we just heard from Howard and Ted, are not written with patients as a target audience. And it's unclear if patients can learn anything about their diagnosis from our standard pathology report formats. So what we wanted to do was understand kind of like what patients are looking at, what options there are, and whether we can make anything better, and really to understand the current state, because we didn't have a lot of information on like what can a general reasonable person understand from these standard pathology reports. So we tested a few different types of pathology reports, and this is the low risk university report. I included low risk given our population here with active surveillance. And so this is what the pathology report looks like. And I thought this was actually what it looked like on the patient portal. You can see that there's a diagnosis of prostate cancer, but it's called prostatic adenocarcinoma. But then the template here is really, really hard to read. This 3/50, what does that mean? 6 here, it's very, very confusing. And so I thought this report was really terrible. And then we actually, and this was what we were tested in our study, but I later learned as we're trying to pilot adding in a patient-centered component that this is actually what the patients see on the portal, and it's even harder to read. Like this is almost impossible for even me to read. So just a jumble of numbers, and you really cannot get much from it at all. So that's just my aside there. So patient-centered pathology reports present the most important clinical data from the pathology report in plain language. And this is what a patient-centered pathology report looks like. So it's a question and answer format. Why do we do prostate biopsies? What are the results? Based on looking at your prostate cells under the microscope, there is prostate cancer. But then it tells us about kind of like how bad is this cancer? So we've got the grade and an explanation here about your Gleason score or a grade group, and we see that it's 1 out of 5. And then how much cancer is there? So it's 3 out of the 16 biopsies. And then that it's a low risk prostate cancer. And the bottom line is that there's a low risk prostate cancer. Now, as we move into the future, we might start even testing things like most low risk prostate cancers can be monitored via active surveillance, talk to your doctor or something like that, to even further moderate people's worry in this case, so that they realize that they probably don't actually have to undergo definitive treatment for this. They can do surveillance. So those are things that we're thinking about. So few studies of patient-centered pathology reports exist. And prior to our study, no previous study directly compared patient-centered pathology reports with standard reports in current use. So we designed a randomized experiment that compared diagnosis knowledge and perceived worry among adults presented with different report formats of prostate biopsy reports. And using this little QR code here, you can get access to the full paper here if you want to, and if you don't have access to the journal, you can see the whole report here. So what was our study? So our study was a web-based sample. We used over 2,000 adults with a prostate and no history of prostate cancer. They were ages 55 to 84, and the race and ethnicity were sampled to mirror the population of people in the US diagnosed with prostate cancer each year. So there's more African American patients diagnosed with prostate cancer each year in the US, and so we made sure that our population matched kind of like what we see in the US as far as incidence. These were not patients. They were just regular people that we said, what can you understand from this report? So they looked at a hypothetical scenario with urology, which led to a prostate biopsy. They were prepared for the range of possible biopsy results as they would be by a typical urologist. So they got all the information that the urologist typically gives. And then they were randomized. So there were 3 different report types, 2 different standard reports, one from that was modeled off of U of M, one that was modeled off the VA, and then the patient-centered pathology report. And then there were 2 risk levels that they could be randomized to, high risk or low risk. So we had the report on the screen. And while the participants were looking at the assigned report, they weren't patients, they were just regular people. While the participants looked at the assigned report, we asked them questions about the report. So they had it right in front of them. Based on the report, we asked, is there cancer present? What's the Gleason score? And what's the risk level of this cancer? We also asked them, how easy is it to understand this report type? And how worried would you feel if this was your report? So what we found was that most study participants could not extract basic information, like whether the report showed cancer, from standard prostate cancer pathology reports. So Ted was able to say, yeah, I saw the word carcinoma and I knew that it was cancer. But in our study, most people weren't even able to match up carcinoma with cancer. So only 39% of people reviewing the standard University of Michigan prostate cancer pathology report could accurately identify that there was cancer present. So more than half of them were getting it wrong. We said, does this report show cancer? And more than half of them said either no or I don't know. And then less than half of the people who looked at standard reports could accurately identify more specific details about their cancer, like the Gleason score or the cancer risk level. In contrast, a patient-centered pathology report effectively communicated the most important clinical data from the pathology report. So here you can see the column that's the patient-centered pathology report here. So how many people were able to recognize cancer was present? 93%. That's compared to the standard university, 39%, and the standard VA, 56%. What percentage could identify the correct Gleason score? 84% versus 48 and 40. And what percentage could identify the correct risk level? That's 93% versus 41 and 36. The patient-centered pathology report was also rated by the participants as significantly easier to understand than the standard reports. So it did a good job communicating the information that a pathology report should communicate. It was easier to understand. We also looked at worry. I don't know why that happened there. There's now this new yellow drawing, sorry about that. So the PCPR format allowed patients to distinguish between risk levels. So over here, you can see this is the level of worry. So from 1 to 5, this is like, I'm not worried at all, to this is, I'm really, really worried. The standard university report, the differences between a high-risk prostate cancer, where you're definitely going to need definitive treatment, and a low-risk cancer, they were having a very similar level of worry. Same thing with the standard VA reports. There's a little bit of difference between the high risk and the low risk, but there's not much. But if you look at the patient-centered pathology report, we're seeing that people understanding that there's a low risk cancer really did lower their worry level. So lower risk cancers were associated with a lower level of worry, and higher risk cancers were associated with a higher risk of cancer. So there's no like appropriate level that someone should worry, but we would hope that if a report was communicating effectively, a low risk report for cancer that would only need active surveillance would elicit a different response than a high risk cancer that would need a definitive treatment. Okay. So our conclusion from this was that hospital systems should consider including patient-centered pathology reports as a supplement to standard pathology reports to improve patient understanding. And we're in the early phases of implementing patient-centered pathology reports for our prostate biopsy patients at University of Michigan and VA Ann Arbor. And with that, I'll take some questions from part one. And I don't know why we're getting these. This is a good time to pause and say, I'm not sure why we're getting these yellow drawings on the slide.
Okay. Because your mouse was dragging on your screen.
It looks like there's a person's name associated whenever it comes. All right, I'm going to try to delete those.
Okay. Do you want to go ahead and grab them, or do you want me to walk you through some?
You can walk me through some.
Sure. Okay, we have Joe asking how significant is HIGPIN? And maybe
that is a good question for the end.
suppose a person, how would a doctor or clinician know if they're dealing with a person that has been previously diagnosed with a mental illness? And how would this affect how they react? Worry.
Okay, so I think that's probably a good question for the end as well. In this section, I just want to focus on questions about a patient-centered pathology report or any questions about understanding kind of what the report means as compared to a standard report.
Right.
Jeff, maybe we should open up those kind of questions if any of the attendees have questions about the report.
Okay.
Raise your hand. Don't get too personal.
Right. Okay. I guess
If I can say something, it's I'm sorry. The reports, whether it's PSA, pathology, and I keep going back to this, is there's a lack of consistency, meaning there's no standardization.
Definitely.
So when you look at a pathology report that I had from a local provider, then I had an Epstein overread, then I had an overread done by Memorial Sloan Kettering. The reports all look different, a little bit different. I won't say which one, but one seemed much worse than the others. As I went back and I looked at each one and I dropped them into spreadsheets and did my own overlay, bottom line, it came out to 1% difference between the core that was found, the percentage, the length, etc. So what concerns me is here I went to 3 different institutions, and that was on my first biopsy. 3 different institutions, you get 3 different reports, but when I do my own, and right, I had the capability and the capacity to do that, I did my own overlays, they're within 1%. What my concern is, now there's going to be another type of report out there. Why isn't there any type of, NCCN says they have all these guidelines, etc., on cancer, AUA. Why isn't there any consistency?
Yeah, that is such a good question. I love that question. Thank you. So you're right. There are so many different I want to pull up the patient-centered. There are so many different reports. There's so many different ways. Some people say, 15%, or they'll say 5 to 10, or, all of these things. And I'll show you in the next section that the diagnosis of prostate cancer is a little bit imprecise. It's kind of like you eyeball it a lot of the time. You can really know what the pattern is, but you probably eyeball the percentage. There's no like fancy computer computing a percentage for us. And so what we did, the patient-centered pathology report was developed by Dr. John Gore at University of Washington in Seattle. And what it contains is the actual information for NCCN to put into to their algorithm to give you the nomogram. And so that's why we use this. So you need to put in your Gleason score, sometimes grade group, but usually just Gleason score, and then the number of samples that were positive. And so that is why we included this data here. And yes, there are so many different pathology report formats, and I think it would be great if we had a standardized report, but we just do not. I think that's a phenomenal thing to get together a national or even international pathology report format. I know at our institution, people do a lot of research, and that's why ours look like this in this box here, because they're able to extract it quickly for research. And so that's what drives keeping the report in this format. And I imagine there's similar driving forces in each institution. Yeah, that is a great point.
Hey, Ted, how about you? You can't stop talking, right?
Well, actually, I was going to make a recommendation, if you don't mind. If you can go back to that patient-centered report.
Oh, yeah.
So while it provides more information than the typical report, I still find it's still rather, I don't want to say clinical, but it's rather just factual and not providing context.
Right.
So if I can suggest, while you give some explanation about the Gleason score, I think it would help to say typically a Gleason score of 3+3 means, it's low risk. It means X. 3+4 means this. 4+3 means that. And of course, everybody's going to be unique, but at least it gives greater context for the scoring, and
Right.
not just a clinical number of your Gleason score is 6 based on, and then all that stuff.
Yes, excellent. So you would like kind of like a line at the end here that says typically patients with low risk who fall into the category of low risk are placed on active surveillance and don't require any additional treatment or something like that.
Something along those lines. So at
Okay.
least
Would
it
you
gives the
like to see other
patient.
things of like how it gets, if it was a 3+4, you would think about it this way? Is that also helpful?
Yes. So at
Okay.
least if you haven't spoken to your doctor, at least you
Yep.
have some information as to whether you should be really worried or not at
Right.
all worried. And of
Right.
course, you still need to follow up with your doctor. That goes without saying. But
Yep.
at least it helps ease some of that immediate fear.
Yeah, I 100% agree. And it's something that we really struggle with because we as pathologists don't want to overstep our role. And we also don't want to piss off the urologists. So, for example, a recent patient at the VA, they had a 3+3 = 6, but their PSA score was 30. And so I knew that this is actually not going to actually like stay a 3+3 = 6. Like they
Right.
need a rebiopsy. Um, and so you kind of get a little bit stuck in these situations. Like, should I tell you low risk, you're most likely going to need active surveillance? Probably not, because you have a PSA of 30. Like, no, that's not going to be where you land. I don't want to falsely leave you to sort of not take this seriously. And we're sort of in the very early stages of having the pathologist give even some patient-centered information. Usually it's like the pathologist, you stay in your box, you don't talk to patients, you don't do anything with them, you just send the report and you forget it. And so this is sort of like an early edge out the door, like foot into the door of communicating more with patients. But I think that it's really important to have some context here, but we struggle with figuring out like what's overstepping, what's telling. We don't want to misinform patients as well, or like reassure them falsely, too.
Sure, but that's why I'm suggesting maybe just like like a template profile.
Yeah,
And with all the legal CYA stuff that says
right,
you still need to follow up with your doctor,
right.
but typically a person with these results means blank.
Right. No, I think that that's really good. And I'll show you at the very end, ChatGPT is already doing that for patients. Like if you plop it in, I have this actually prostate bot that I want to show you at the end, but it's giving that context. So I just feel like if something out there is already giving that context, like we as pathologists should be able to give it too.
Exactly.
I absolutely love that statement because when I charted the pathologist question about my test, all they did was refer me back to the ordering person, which was not an MD.
And
I
doctor,
absolutely love that answer. Thank you.
yeah, doctor, I want to bring up a question that Joe I asked, which I think is pretty fair. How do we get a patient-centered pathology report? So what is the status of this idea? How widespread are these reports? Are they really widely available or not?
They're not widely available right now. I think that John Gore's group at University of Washington did them for a while, but then there was a change in the pathology information system there, and they were not able to like generate them anymore. We are generating them, starting to generate them now. I'm going to test them in like a phased rollout of a quality improvement project. But there's a lot of technical and complicated issues to get them actually in the pathology report, and looking okay. Like to get something that looks this beautiful, it's very, very hard to do because it goes from our pathology system into Epic, like the electronic medical record, and then it goes to the patient portal. And at each point there, formatting is stripped and reinserted. And so to get these in here looking even decent is hard. And to ask the pathologist to do an additional layer of work has also been met with some resistance in some groups. It's extra work to put one of these in, and it's not reimbursed. And pathologists have been sort of like the culture of pathology is once it leaves our office, like it goes to the urologist. It doesn't go like we don't think about it going to the patient. That the system is not built for that yet. And they just think about it going to the urologist. The urologist should be able to figure it out. The patient care aspect is not our responsibility. So that's a lot of the culture. So that kind of needs to change to say, actually, like most times we are now the people who give the result to the patient. Like we are those people now, whereas traditionally we haven't been. So that's kind of like an overall, change of what we think our role is. And that takes time.
Cathryn, in pacing your program, can we fit in a couple more questions now, or do you want
Um,
to move
where are
on?
we? Let's go to the next section, and then the final section will be really short. So at the end of the next section, we can do some more. But just save them for now, and we'll go through the next section. They want to make sure we do a pathology explanation clinic. Is that okay?
Yeah, you're the
All right.
boss.
Okay, great. Thank you so much for those questions. They were excellent. I really appreciate it. Okay, so part 2 is what happens when a patient meets with their pathologist. So this is called a pathology explanation clinic. And thinking back to the little diagram that I showed you in the beginning, the triangle here, we've got the patient, the pathologist, and the treating clinician. So a pathology explanation clinic is fit in right between the patient and the pathologist. So this is the actual meeting between the patient and the pathologist to discuss the report, look at the cancer under the microscope, and talk through everything. We also send a note to the another note to the treating clinician. And a lot of times we also do like a phone call, especially when we notice that there's like a patient safety issue or something like that, which was surprising to us, was actually fairly common. We found a fair number of issues when we sort of looked at it through the eyes of someone who's a pathologist seeing a patient. So we made some impact in quality and patient safety here too. So for the purpose of this group, I'm going to do a mock Pathology Explanation Clinic for Ted's pathology report. He was kind enough to say that that was okay. And so I'm just going to talk you through, like, you all are undergoing a pathology explanation clinic, but we're using Ted's results. Okay, so hi, I'm Dr. Lapedis. I'll be doing your pathology explanation clinic. The overall goals are to improve patients' understanding of their diagnosis and to enable patients to make informed and values concordant decisions about their healthcare. So that means they have all the information that they need and they're able to pair that information with what their values are so they make the right decision for their own healthcare. The scope of the Pathology Explanation Clinic, we're going to describe the normal prostate histology, we'll discuss the Gleason scoring system, and we'll review biopsy reports in your slides. So this next part here is like my disclaimer about me staying in my own lane, because clinicians will feel quite, we did some interviews and we have a paper about clinicians' attitudes towards the patient and the pathologist meeting. And one thing that was very, very important to them is that the pathologist doesn't make recommendations about treatment or prognosis. So I always tell them, go ahead, ask all of those questions. My job is to synthesize those, put them together, and I put them in a note to you and your doctor. So if they say, hey, you know, I have high grade PIN, should I get treated for that? I'll say that's a question for your urologist, and I can show you what it looks like and why we call it that, but your urologist will be the one who helps you figure that out, what's right for you. More often it's questions about like high grade cancer and what treatment to do. And I just say, well, write it down so that it's organized. So we're at least organizing questions as well. And people are very understanding of that. They understand that my expertise is not in treatment and prognosis. Okay, so we then go through what normal prostate looks like under the microscope, and we start with the prostate cell. Can you see my arrow here? Could somebody just tell me if you can see my arrow? Yeah, okay, I see Jeff nodding. Okay, so this is a prostate cell right here. This purple dot here, that's the nucleus or the brain of the cell. And this pink, that's the cytoplasm or the body of the cell. The purpose of the prostate is to produce some fluid that nourishes sperm and assists with fertility. And it does that by secreting the fluid into this gland. So this whole thing is a gland, and the fluid gets secreted into this white space here. This is the lumen of the gland, okay? When it's star-shaped or like crab-shaped, this one kind of looks crab-shaped, or circular, there's this like big white space, that tells us that it's normal or benign. So that's what normal prostate normal prostate tissue looks like, this star-shaped or circular white space lumen, okay? Another thing that tells us that the prostate gland is benign is that there's 2 layers of purple dots. So there's one layer here, and then there's a second layer on top. And you can see in the picture, the real picture under the microscope, that there's one layer of cells here, and then a second layer over top. And human tissue is messy. So sometimes it's like, oh, are there 4 layers here? Are there 3? But as long as we're kind of seeing that there's 2 layers, at least 2 layers somewhere, we know that that's normal. Okay? So I would stop and ask questions. We're going to have a time for questions right after this. So if you have any questions on anything, just write them down. We can go back to it. So the grading of prostate cancer. What we do as pathologists is we ask ourselves, is it cancer? And if it's cancer, how close to normal is it? How much do those cells look like normal cells? And that tells us about the Gleason pattern, which determines the Gleason score, which determines the Gleason grade group. So it all comes down to pattern. So I'll talk about the Gleason pattern. So the patterns that determine the Gleason score were historically 1 through 5. So they thought there was pattern 1, pattern 2, pattern 3, pattern 4, pattern 5. Over time, we learned that patterns 1 and 2, they're not cancer. So the lowest risk pattern that you can have is pattern 3. So that's where we start. We start at pattern 3. The next pattern is pattern 4, which is more intermediate. And then pattern 5 is a high risk pattern. So what do these look like under the microscope? Gleason pattern 3 it looks really, really similar to normal in that it's got these sort of star-shaped or circular white spaces. The only difference is instead of having 2 layers of those purple dots, it just has 1 layer of those purple dots. But it's forming these nice circles, and it's got the white spaces in the center of them. So these are discrete, well-formed glands. Gleason pattern 4, you don't have these nice big white spaces anymore. You kind of have more fusing. So it's trying to make a gland. It's trying to make that kind of glandular circular structure, but they're sort of stuck together. They don't have big white open spaces. And then Gleason pattern 5, the cells are doing whatever they want. They can either be little cells scattered throughout the tissue or sheets of cells. So a little bit more on Gleason pattern 3. So down here at the right, you see normal, and we have 2 layers. So there's 1, 2, 3, that's 1 layer. 1, 2, 3, that's 2 layers. That's the normal. When you have cancer, this is kind of like the first thing that determines it's cancer. You just have 1 layer of these cells, and often they have these prominent dots inside them in the center. So if we look over here, but they're still making circles. They're close to normal. They've got these big white spaces in them. These will when you get cut deeper in. So it's, not as simple as I'm making it, but this is generally what we can expect. So we've got this nice circle here. We can draw a circle around it and that nice white space. And then we've got these prominent dots here and only 1 layer. So that tells me it's a Gleason pattern 3. Gleason pattern 4, there's 1 layer of cells like in the Gleason pattern 3, but the glands are not making circles anymore. They're kind of fused together, and you can kind of like track through, like you can go all the way around the tissue without ever going into the pink. This is the stroma in the background. So all of the cells are kind of connected or fused together. And that's Gleason pattern 4. And given the audience, I'm not even going to talk more about Gleason pattern 5 right now, but happy to answer questions afterwards. So what we do is we take the patterns, we look under the microscope and we say, okay, is there cancer, is there not cancer? How close to normal does it look? If it looks really similar to normal, then it's pattern 3. So that becomes the Gleason score. The Gleason score is the most common pattern plus the less common pattern equals the total score. Now you'll notice here there's 3 plus 3. That just, when there's only 1 pattern, it's pattern 3. So we only have, in TED's biopsy, we only have pattern 3. So we repeat it. So it's a 3 plus 3 equals 6. But that just means all the cancer is Gleason pattern 3. Okay. So then we translate it into the grade group. It should just say grade group. Sorry about that. So it translates it into the grade group here. So the risk group, so you have the Gleason score here. So in this case, it was a Gleason score of 6. That means it's a grade group 1. They're just an equivalent thing. It's just if you're in this Gleason score, you become that grade group. There's nothing more to it. And then that translates into a risk group, into a very low or low risk group, which is determined by some clinical factors and some volume factors here. And then the other scores are here. So there's the Gleason score 7. As we talked about, the most common pattern plus the less common pattern is the way the Gleason score is made. So if you have mostly pattern 3, that's the lower risk pattern, and that comes first, that matters. That puts you in grade group 2. Versus if you have mostly pattern 4, that intermediate risk pattern, and a little bit of pattern 3, then you're in grade group 3. So that's how the Gleason score and the grade groups are related to risk level and to each other. So now I'm going to show what normal prostate looks like under the microscope. And then we're going to take a look at TED's mock slides. So one more primer here. We've got normal prostate, 1 layer of cells, 2nd layer of cells, those purple dots, and they're either making circles or star-shaped white spaces. So multiple layers of those nuclei, circle or star-shaped white spaces. And then let's take a look at TED's mock slides. So the first thing I always do is talk about normal. So 11 out of 12 biopsy samples showed no cancer at all. Normal prostate, no cancer. And each one of these cores, this is just an example of some of the cores, they are on a slide, and we look at each slide very, very carefully. So 11 out of 12 biopsy samples showed no cancer. I would show also that this is what your normal looks like. So here's a white circle here. Here's a sort of a star-shaped white space. And we've got multiple layers of those purple nuclei. So no cancer. So 1 out of the 12 cores showed cancer. In the 1 core that was positive, there was only 5% cancer, just a little spot. So this is the core here. And then this is the cancer. So that's where, and we'll zoom in on that. But this is how much of the core is occupied by the cancer. It's just a little tiny spot. And now let's look closely. So this is really, really, really zoomed in. So this is the zoomed out version. Now we're going to zoom in right on that red square. And this is the little spot of cancer here. So you can see that there's these nice white spaces. There's forming circles. You can see all the pink around it, and you can draw a circle around it. We've drawn a circle around a couple of these here. And this is all pattern 3. So it's 1 layer of cells with the prominent dots. And you can see the 1 layer of cells here and these prominent dots, these nucleoli. And then you've got the white space there, and you're drawing a circle around it. So it's all Gleason pattern 3. So then I would go through line by line the report. I'm just going to pick out a few things here in the interest of time. So this shows adenocarcinoma, which means prostate cancer. And then the Gleason score, as we talked about, it's all pattern 3. So it's the most common pattern plus the least common pattern. They're all the same in this one. So it's 3 plus 3 equals 6. And then there's 1 core involved, and it's only 5% of that core that's involved. So that's everything that you need to know from this report. I'm happy to answer other questions if things come up. But I would tell them the overall summary is that based on your biopsy results, you have very low risk, Gleason 3 plus 3 equals 6, grade group 1, prostate cancer. Knowing your PSA and radiology and rectal exam results may affect your overall risk. And so then I just want to show you a little bit about what our research tells us about the Pathology Explanation Clinic. So that's kind of what one looks like. Our research, and I might go a little bit fast through this because I want to make sure we have lots of time for questions, but so what our research tells us is that pathology explanation clinics are really effective. This is the overall conceptual model. We think that what they're doing is they're giving some information that helps manage uncertainty and enable self-management. And they are impacting patient understanding. They're allowing the patient to feel more involved in their care. And patients across the board give us 100% satisfaction ratings. Things that these proximal outcomes influence are a quality medical decision. So people are able to make a high quality decision that's, it's informed and it fits with their values. And it also helps with emotional management, emotional well-being, and less suffering. We find that patients are more comfortable choosing active surveillance when they really understand what's going on in their prostate biopsy and the amount of cancer that they have there. So we've done 2 small studies on this, and they've been implemented, and pathology explanation clinics are now implemented at the VA in Ann Arbor. And to my knowledge, it's the only pathology explanation clinic at a veterans hospital at all. So I really appreciate our chair, who was super supportive of this. So we did a small study of 10 men who had a pathology explanation clinic, and then we followed them up over 6 months. And we found that understanding of diagnosis was improved. This supported patients first in their visit with their urologic oncologist and later in making a high quality treatment decision. So here's some quotes from active surveillance patients. They said, "It was important to me to see the cancer cells and notice how much it had spread or not. That was part of the database that I had to discuss next steps with my surgeon or my doctor." Another quote is, "The most interesting thing to me was the 3 plus 3 cancer cells. They don't even look like they're going to turn into something bad." And then another one, just relevant for this case, 5% meant this little tiny dot. We also found that PECs brought a sense of emotional ease. So this feeling of people being in panic, once they had their pathology explanation clinic, they were more calm. And we're finding that in veterans, even with high-risk diagnoses, that just getting a sense of what is going on here with my biopsy report is bringing a sense of calm. So this is a quote here. The initial stage was probably the more traumatic, but at this point, this is directly after the Pathology Explanation Clinic, I feel like I'm at the point of acceptance. Let's go to step 2 to see what the treatment is and follow through on the process so I'm in a good state of mind. The urologist also told us that the visits were really different. So this is one quote from a urologist. Visits with my post-PEC patients were really different. It was obvious. My first impression was that anxiety levels were a little bit lower than usual for those men. Typically, I take a significant amount of time to explain how we came about the Gleason scoring system and how that's linked with prognosis. But in post-PEC patients, that time investment was not necessary, and that allowed for more time spent in the clinic discussing future steps and treatment options. So we're seeing that, okay, they've got this bolus of knowledge through the Pathology Explanation Clinic, and then when they have their visit a week or two later with the urologic oncologist, they're in a much better place to say, okay, these are my questions. They're all laid out in the pathologist's note too. And this is what I'm trying to figure out. Like they're at the point where they want to have a conversation about treatment decision. And then PECs also improve patient safety and quality of care. So based on the PEC, we were able to make sure that several of the cases were re-reviewed for diagnosis. Most of the time, that's our practice, but some cases get slipped through the cracks. And some of those led to minor changes in the diagnosis, which allowed the patient to choose active surveillance. We also identified a misdiagnosis that was really complicated, and because of the different formatting of reports that people have mentioned, the urologist said that they would have missed that there was a misdiagnosis and a change in that diagnosis when we re-reviewed it. And this allowed the patient to choose active surveillance when they were previously going to be doing surgery. So that's really important. In the VA Ann Arbor, as I said, we established our first permanent pathology explanation clinic based on the pilot data at U of M, and I've seen over 60 patients so far. Satisfaction with the clinic from the patients and their urologists and radiation oncologists has been really high. We have a tight team and we're working together to really make prostate care optimal there. So 100% of patients would recommend a PAC to a fellow veteran with prostate cancer from our VA group. And we found that PACs significantly improved diagnosis knowledge and reduced worry. Initially, when we talked to some of our clinicians, they said, yeah, some patients might like a pathology explanation clinic, but they have to be like super, super educated, like maybe the engineers or the people who are doctors themselves. Yeah, they'll like to see it, but nobody else will. And at the VA, we have a population that has, I think most of our PEC patients are either high school graduates or they have some college or associate's degree, and they're loving it just as well. They're getting as much out of it. So sometimes there's a little bit of bias in medicine about who's going to benefit from this, but we're finding at the VA that regardless of education level, regardless of background, people are really enjoying seeing their pathology. They're getting a lot out of it, and they're really improving their understanding of their diagnosis. So after the PEC, 100% of patients knew their Gleason score versus 23% prior to the PEC. These patients had all talked to their doctor at least once. 90% knowing their grade group, 84% knowing their risk level versus 19 and 26% prior to the PEC. So this is a quote from one of our veterans. Most people don't have a medical background, and this program broke things down very well and clearly. He noted that he felt more informed about what's going on and more aware going forward. He said the PEC takes a lot of the fear out of it. Everyone hears cancer and freaks out, and this helped. That was just there. And then we also identified and corrected many quality and patient safety issues. So there were 4 diagnostic miscommunications. A diagnostic miscommunication is when the urologist interprets the report differently from what the pathologist intended. One example from our study is that in one report, there was just cancer around a nerve. So the convention is that we don't grade that. We just say there's cancer around a nerve, figure it out. And the urologist saw that there was no specific grade listed and just told the patient, you don't have cancer, see you later. When actually they did have cancer. And so we were able to catch that, tell the urologist, hey, this actually says there's cancer, not no cancer. And the patient was able to be appropriately followed. There were a couple other pretty stark diagnostic miscommunications, which resulted in treatment management or treatment plan changes. So that's pretty big out of, only the 60 patients that we've seen so far. So the PEC was able to identify a lot of these diagnostic miscommunications and correct them. And then we also changed our reports over the time period to make them more clear. So over the course of our time, there were 4 diagnostic miscommunications, 2 pathology report errors, just like it was obvious there was typo when I looked at the slides and the report, they didn't match. And then 2 classification of risk categories. That's like someone says you're in unfavorable intermediate, another person says you're favorable, like figuring that out listed differently in the chart. And then 1 identification of unmet patient needs. That patient actually, just at the time of my visit with them, needed to go to the hospital due to heart condition. So my thought with pathology explanation clinics is that they really support continuous improvement in patient-centered pathology communications because they're identifying in real time, like day-to-day quality and patient safety needs and allow us to change our system to make it better. They also identify care team communication gaps. So sometimes, the urologist is consistently reading things in one way, but we mean it in a different way. So we can pick up on that. And then it also supports the development of patient-centered reports and educational tools that can be used in the place of pathology explanation clinics for a broader audience, because right now it's not really realistic to give pathology explanation clinics to everybody, because I think it would just require so many more pathologists and we don't have them. So we need to develop some tools that could be used to do this better. All right, so that's the end of part 2. That's my longest section by far. So my next section is like 5 minutes. So feel free to ask any questions here.
Okay, Howard, we're just going to go with the patient explanation clinic questions this time. I don't hear Howard. Okay.
That sounds good to me.
Okay. Doctor, could I ask, there's been a lot of changes in regarding Medicare, changes in Washington, changes with insurance plans. Can you tell me if insurance, be it Medicare or supplemental, will cover the patient explanation clinic and related activities?
Yeah, so this is a really, really important and interesting question. So currently, they're covered in Massachusetts, and they have been covered by Medicare and Medicaid there as just regular doctor visits. So they're being billed as like a regular new patient doctor visit, and they're being covered. As part of the VA, I do these virtually because a lot of our patients are in rural communities. And so I don't want them to have to drive another 2 hours to like do something that I mostly do over the computer. And those I'm allowed to bill for a virtual new patient clinic visit. It's through the VA though. And so it's a totally different system. VA is like a closed healthcare system. I'm not sure. I think we have a breast pathology explanation clinic at University of Michigan, and I believe they have just started billing them. The billing code that we're putting under is a new patient visit. And so it should be covered by Medicare and Medicaid as long as they haven't been flagged for some reason that like you can't have this type of a visit with a pathologist, because it's just a code for a regular, like you went to see a new person. But it's an evolving area that we're still really learning about. And so many changes in Washington and with different coverages that I think we're just going to have to wait and see kind of like what gets flagged.
And does that apply both to VA and non-VA patients?
It would not apply to VA patients because VA is a closed system. But to my knowledge, I'm the only person who does VA pathology explanation clinics in the VA system.
Okay, and we have another person asking a question.
Yeah.
Frank, Don asks, is it normal for a patient to have direct access to his or his pathologist? He says it's not happening in his world.
No, it's not normal at all. It's completely unusual. And it's something that we're trying to learn about to see if that's helpful, to see what we can learn and change. And right now we found that, yeah, we can make a huge difference in how much people are understanding. And we also identify all of these patient safety and quality issues, so that they're a very important thing to integrate into the health system, but it is not normal. However, what I would say is that we did a survey of pathologists and asked them how how would you feel about interacting with your patients? And 85% of them said that they were definitely interested in having interactions with patients to explain their pathology results. So what you could do, it might take a little extra legwork, but most places, if they don't have a pathology clinic set up, which hardly anybody does, you can call your pathologist, you can get in touch with them. Their name is going to be at the bottom of your report. It'll say signed out by, and then it'll have their name. And you can call the pathology department. Usually you'll have to do some Googling, like University of Michigan Pathology Department. Just call the main number and say, I have a question for my pathologist, and you should be able to reach somebody that way. And often, if you actually get to talk to your pathologist, which hopefully you will, they'll be very, very happy to explain anything in the report for you. And most of the time, they'd be very happy to show you their slides too, but it's going to take some extra legwork. And even if you don't have a specific covered visit, most pathologists will take the time to show you what's going on. They may or may not have training in how to explain that to patients. So I'm not sure how complete or comprehensive it would be, but you should be able to talk to a pathologist because most of them are interested in talking to patients.
It looks like Ted has his hand up. Ted, fire away.
Thank you. So similar to my comment earlier around putting context around the grade group or Gleason score, I would also suggest putting a little bit of context around the percentage score. So in my case, it was 5%.
Right.
But again, I didn't know what that meant. What
Right.
is that a typical volume? Is that large? Is that small? So
Right.
again, it just adds another layer of understanding to the patient when reading the results. Because it was only once I met with my oncologist and he encouraged me to go on active surveillance because my first thought was, let's get it out, regardless of what it takes. Not that I want surgery, but other options. And he said, no. You're too healthy. We're just going to watch this. So again, had I known all of that with the report, I would have been, much happier for those few weeks.
Yeah, of course, definitely. Yeah, I do. So in the beginning, and I didn't do this with everyone, but I do kind of say okay, what do you know so far? Where are you in your treatment, decision progress? Where, have you seen your urologist again? Usually they've gotten a phone call and it's just been most people, all they take from it is that they have cancer. That's it. They don't know the risk level. They don't know the grade group. They're just my doctor called that I had cancer. I have another visit in a month or something like that. And they're, in this space where they don't really know, which is shown by, low percentages of people knowing their risk level, their Gleason score, and their grade group. So what I do try to say, especially when people are really anxious, is I say, you had all of these biopsies, you had 12 biopsies, and this is a tiny dot on one of them. And this is a zoomed in image of one of them. And it's this tiny little spot. This is a very, very small percentage of your overall. And I do try to emphasize that. Sometimes if they say, I'm considering active surveillance, does that seem okay? That's kind of where I get a little bit in the I don't want to overstep my boundaries, but I think that I try to be as reassuring as possible. And now that I've established trust and rapport with our urology and radiation oncology colleagues, sometimes I will have them give them a call right afterwards and just say, hey, he was still really nervous. It's this tiny spot. Can you give him a call? And other times I'll say, because I want to make sure that there's not something else I don't know about. Maybe his first PSA was 4, but now he had a repeat and it was 15, I want to make sure of those things. So, but I will tell them this is a very, very, very small amount. And if they're saying something I'm considering active surveillance, yeah, a lot of people who have this same thing are typically doing active surveillance. And so supporting them in that.
Yeah, Dr. Lapedis, there are some pathologists like Dr. Jonathan Epstein and Dr. Ming Chow, who we sometimes refer patients to. And I think that those doctors, in fact, are willing to take that extra step, and give some guidance on whether they would recommend active surveillance. But so what's the difference between them and you?
I think if I'm not mistaken, Dr. Epstein's in private practice now. Is that correct?
That's right, in New York.
Yeah. So you get a lot more leeway in private practice than you would with
Well, but
in a group.
he did that for
He did it
30
before.
years
Yeah.
at Johns Hopkins.
Yeah. Potentially, I am not like a world expert in pathology, and I am working with urologists who are world experts in treatment, and they prefer that I kind of leave it up to them, leave that part up to them. There's a lot of fear from clinicians about like pathologists overstepping boundaries, and then they go to the urologist and they say, "Oh, my pathologist said that I should have active surveillance." And they say, "Well, actually, you have this large nodule. Like, did your pathologist know about that? Or actually, I see some extension into the capsule. Did your pathologist know about that?" And so I am not comprehensively evaluating their radiology, and maybe Dr. Epstein is. But my previous research in how do we make pathology explanation clinics acceptable and sustainable, it's the first step is being really careful about staying in your lane, and not going into the realm of the urologist. And I don't know if maybe over my career, I think I've been doing pathology explanation clinics for a couple years now. I've only done 60 patients. Maybe over my lifetime, I would say, oh, I know that, this urologist always does the X, Y, or Z, and I would feel more comfortable with that. But right now, I would much rather be in the position of connecting them with their care provider who's going to help them make their treatment decision than overstepping my boundaries, pissing that person off, and making the patient confused. So I just err on the side of caution there.
I'd like to bring up one more question, and then I think you have another section, right?
Yeah, it's just a very tiny little section.
Okay, if I could just, somebody brought up the question of what percentage of the population with prostate cancer have Gleason 6. And I would ask too, what percentage are favorable 3+4?
I do not know that right off the top of my head. I'm sorry, I'll have to get back to you.
Okay, so that's fine. Why don't time is waning here.
Yeah.
I think we have about 9 minutes left, unless you're
Okay.
willing to stick around a little bit.
Okay, so I'll go over my next part here. This is just a few helpful resources for your next pathology report. So this video here, if you are sort of interested as a scientist, like what happens when my biopsy comes from my prostate and goes to the lab, this is a nice video that gives like a full overview of how it all works. So that's just if you're interested in more information. If you have questions like the high-grade PIN question about the words in my biopsy report, mypathologyreport.ca is a phenomenal resource put together by Jason Wasserman, if I'm correct. Is that right, Howard? I know
Yes.
you.
Yeah.
And he's phenomenal. He's written a ton of these. Oh yeah, his name is right here. And there's more context on here. So this is atypical small acinar proliferation, but you can also put in high-grade prostatic intraepithelial neoplasm, which is also not cancer. And it gives you some more context here. It's not cancer, like ASAP is not cancer, and is not considered a precancerous condition by itself. It's a finding that may indicate the presence of cancer nearby or in unsampled areas of the prostate. So there's a little bit more information here. I find a lot of the times these articles are fairly advanced, though. They're pretty advanced, some of them, but they do offer some context, and I think it's a really great and helpful website. But if you have trouble with some of the words in there, I have one more resource here. So this is for when your report is impossible to read and you're desperate for an overview. So I'm going to share this here. So this is Prostate Pro in Weiser Prostate Center. And I'm just going to copy. This is like just a dummy report of low risk prostate cancer, and it like de-identified and slightly altered. Okay, so you have this crazy report here. You can still see my screen, right? Yeah?
Mhm.
Okay. So if you copy and paste it, so you're copying and then pasting it into here, all of this craziness. this chatbot does a pretty good job at summarizing it for you. What I have noticed though is occasionally it's inconsistent, and it's sometimes not reliable. So it's kind of like, here is a decent summary. So this tells you your Gleason score was 3 + 3 = 6, considered low-grade cancer. This is the lowest grade given for prostate cancer and often indicates a slow-growing cancer that may be appropriate for active surveillance. The percentage of cores is here. And it says, that there's grade group 1 cancer. Active surveillance might be appropriate option. So this is pretty powerful and cool that it can take this, crazy wonky report that's, I find, impossible to read and turn it into something that makes a little bit more sense. But the caveat is that it's not always reliable, it's not always accurate, and it gives different formats. Like I've entered this 3 or 4 different times, and I get a different output every single time with slightly different answers. So use at your own risk, but I would say most of the time it's doing okay.
Cathryn, that's why we want to get a second and third opinion.
Well, not from
A
Prostate
joke.
Pro
A
bot.
joke.
But yes, I always am a big fan of a second opinion, because what one pathologist might miss, if you have it read by a second pathologist, you'll really reduce the risk of any sort of errors there. Yeah. And
So you linking in now for your next batch of questions?
yes, I just wanted to say thank you. This is my team. A special thank you to Dr. Darius Amjadi, who has let me establish the Pathology Explanation Clinic at the VA. He's really, a thought leader there in allowing me to dedicate my clinical time to that. And then this is my whole team, and they're just a phenomenal group of people. And Dr. John Gore, who is the creator of the patient-centered pathology report, and who let me use it to study the reports as compared to standard report. So thank you. And then this is my last batch of questions for everyone.
Yeah, Dr. Lapedis, thank you for your excellent presentation. As one of the attendees said, is 16 years on active surveillance, and nobody's ever explained the cellular structure to him. So that's pretty exciting. But I want to segue from your I want to ask that you send us the 3 or 4 links for resources, and we'll put it out in in the ASPI newsletter.
Okay, great. Yeah.
Yeah, but I want to segue from what you had brought up at the Weiser Cancer Center with AI, because we got one question through email, actually from a physician with prostate cancer. And he said, would AI interpretation of pathology offer guidance? And then he said, could it be used to generate a list of options and basic information? At a minimum, could it be used to discuss with our physicians? And you sort of answered that, but maybe you could take another
Yeah,
bite.
so I want to make sure I'm understanding the question correctly. So question is,
And I think he's saying, how useful is AI? Can it generate options that we can discuss with our doctor, with our
yeah, so I think the thing with AI is that it is useful. And you can copy and paste really complex and like computery data into it and get pretty decent answers. The thing that worries me the most is that it's inconsistent. It's not always giving the same thing every single time. And sometimes the more questions I ask, the more it sort of gets turned around and might say like something about high risk cancer, throw it in there. The more questions I ask, the more it seems to kind of degrade and not be as thoughtful or useful. So I think that there's some work to be done there. I would like to see it take any pathology report and consistently give you like an output that was really straightforward, similar to the patient-centered pathology report, with the addition of the context. I think Ted's point on the context is really, really important. It seems like somehow urologists and other clinicians don't get mad at the AI if it tells you, you should go on active surveillance. But if the pathologist tells you, like, that seems to be like a different type of interaction. They say, this doctor, like having a conflict between treatment recommendations and doctors, especially if that doctor is a pathologist and doesn't have training in treatment recommendations, like that's where it gets things a little bit tricky. But I do think it's so important for patients. So I'd like to be able to figure out a way to do that. And I think I'm working as part of the Wiser Prostate Cancer group now. And I think that we are going to start low without the context, like at the most basic. And then I think we'd like to add in the context over time. Sort of start with it, not offending anybody, and then move up.
Howard, we
let
have
me,
a couple of hands up. I
I
wanted
was going to
to,
call
yeah.
on George Diaz, I think here in Chicago.
Well,
George?
Michael Wynn has been waiting too.
Well, George, then Michael.
Okay. Well, thank you, doctor, and thank you, Howard. Very informative. Doctor, why is it that a Gleason score is not generally assigned to intraductal carcinoma?
So intraductal carcinoma is within the duct. So how I talked about how there's two layers of the cells. If there's two layers of the cells, that's sort of normal. So that's true for most cancer. All of this is sort of a simplified version so that patients can understand it. Intraductal is within those basal cells there, so it's within that duct there. And so it's a different process, and it's not assigned the same grading. Like, it makes different shapes, it behaves differently, and so there are these basal cells around it. But it's still cancerous inside, and so we're just not able to grade it. We don't have a grading schema for it. Gleason only works outside of the ducts.
Thank you.
Yeah, Mike Wynn.
Doctor, thank you so much. Several expert pathologists seem to emphasize quite a bit about cribriform, both the large one and the morphology of the cribriform glands. Why many of the pathologist report from even Center of Excellence do not mention anything about cribriform?
Yeah, so that again goes back to the differences in reporting. I believe that it's the recommended standard now to put in whether there's cribriform formation or not. And I know that we do it at the VA and at University of Michigan. We'll put cribriform in there. If they're not, maybe they're a little bit behind the times. I'm not quite sure the reasons. As we discussed, each institution is different, and I'm not sure why. But I believe the major recommendations are to include cribriform within your reporting at this point. So I'm not sure.
Thank you.
Well,
Howard?
okay. Yeah, I can pick this up, but maybe you can follow, Jeff.
Sure.
Bill Birdsell brings up Artera AI, and there's which they use artificial intelligence to basically analyze the biopsy results. Do you have any specific thoughts about Artera? I think they claim that they can rule out a next biopsy in 60% of patients.
Yeah, I think that's very, very interesting. I don't know anything about that. I do know that between experienced pathologists, there's frequently disagreements. So I feel like AI is only as good as the gold standard. So you would need to have, a really good gold standard to train that AI, which maybe they do. Yeah, I think that AI will be useful in the future. I saw this a question about the subjectivity, but there is subjectivity in there. My 5% volume might be somebody else's 10%, and my 3+3 might even be somebody's 3+4 with 5% pattern 4. There is subjectivity there. There is kind of this range. And so maybe AI is able to help us narrow that a little bit, maybe help us do better percentage calculations. And yeah, so to be determined. But I'm hesitant to sort of dive right in and say, oh yeah, it'll like fix everything for me at this point.
Yeah, Jeff, maybe you can throw a couple of questions out and I'll come back.
Sure. I want to be respectful of your time and the doctor's time, so we can go ahead with a few more questions. Doctor, is that okay?
Sure, yeah.
Yeah.
Let's maybe do to like 140.
Okay, wonderful. I see beautiful pictures of your family. I know you want to get back to them, so I'm being mindful of you. Sure. What about the NCCN and the American Urological Association, based on your model this morning of 3 sections? How do they weigh in? Are they supportive, neutral, or otherwise?
Of pathology explanation clinics or
Yes.
of patient-centered pathology reports, I honestly don't think that they have any opinion on them. They're a small percentage of people are doing them right now. I know that our urologists, I'm putting in the chat to everybody just the summary of high-grade PIN in case we don't get to it
Sure.
from mypathologyreport.com, which is really nice. So yeah, I don't think that most people know about these. This is a very small program, only done by a couple places across the U.S. And I don't think many people know about it. I don't think anybody's weighed in on it. The pathology groups, like the College of American Pathologists and ASCP, both of those are in general like supportive of it. But as far as like making sure there's reimbursement codes and figuring out how everything works and like training pathologists and having departments give their pathologists protected time to do that. That is all still in its like very, very, very early stage. I think some pathology departments are like, oh, if you want to meet with patients on your own like volunteer time, fine. But to say, you know, I want 20% of your clinical service to be meeting with patients, that's really, really unusual. And that's what Dr. Amjadi, our chief at the VA, has let me do. And that's been huge. But I think most places people are kind of squeezing it in, and that's just not very sustainable. People are not, they're going to get burnt out and not be able to do it. So I look forward to, you know, bigger institutions like in other fields weighing in on that. But right now, it's in its, you know, very, very, very early form.
Maybe one more question. Bill, you want to fire away?
Yes, I do. Quite a few of members of our audience fall in the 3+4 category, and there's
Yes.
always a lot of confusion as to just, how gray is that gray area. And maybe you could just give a very quick overview of where the explanation comes in of, well, the most common pattern we found was 3, and then we found some 4. And
Mm-hmm.
it would seem that if you had this tiny little spot of 4 in one core versus maybe another person that had a higher volume of 3 and then much more of 4, how is that distinction? Um, how do you draw that distinction?
Right. Okay. So when I have people who have a 7 with a low percentage of pattern 4, what I talk about is first so I'll say your most common pattern is 3, and then your less common pattern is pattern 4. So it'll look like this. And I'll say that this really matters, that your most common pattern is 3 and your less common pattern is 4. So when there's less than 50% pattern 4, then 4 comes second. If it's more than 50%, 4 will go first. So typically people who are on active surveillance with a percentage pattern 4, it's a low percentage. And what we frequently have in the report is a list. Let's see if I can find, there's a 3-3 here report, but
You kind of show an image.
You want to share your screen if you're
yeah, I was just looking through so I could share more easily. But they'll in the report, it will say the percentage of pattern 4 is like 5% or 15% or something like that. So when I go through in the Pathology Explanation Clinic, I'll say most of your cancer was pattern 3, and I'll give the percentage. I'll say it's 90% pattern 3, 10% pattern 4, and I'll show them. Here's the pattern 3, and here's the pattern 4. Sometimes it's intermixed, but I'll show them exactly that. And then I will show them in their report where it should always say the percentage of pattern 4. And let me see if I have a good old one. I do not have a good old one up right now, but they should have the percentage of pattern 4 listed out there. And I'll explain that this is a very small percentage. And when that's the case, a lot of people do choose active surveillance. Yeah.
Thank you.
I think we better let the good doctor go, Howard and Bill. Are we in agreement? She's got family.
Well, she's the boss, like I said.
Wow.
Yeah, Cathryn, thank you so much for spending the time. It was really an excellent presentation. You shined a lot of light in dark places for patients on active surveillance and beyond, I'm sure. And what can I say? Maybe you'll come back and answer some more questions sometime.
Sounds great. Thank you all so much.
Thank
I
you,
really
doctor.
appreciate
Thank you.
all your questions and interest in this work. So thank you.